Welcome to Urban Renal Talk with Tamika.
And Steve, what's going on, Tamika? Long time.
I know, right? How you been?
Pretty good. How about yourself?
I'm well.
How's life treating you in this COVID world?
Oh, I'm adjusting. I think everyone's starting to adjust. I think it's become a new normal where you just roll with it.
Right. I know. I'm seeing people with masks, without masks. It's like, both sides, both ways,
right.
And I just try to protect myself and make sure, my family's protected.
Yeah. I'm seeing reusing the disposable masks more, and they should be throwing them away. I've been seeing people, it's been really dirty and they're still wearing it.
Oh yeah. That's crazy. I mean, at the clinics, we normally put one on and remove it. We go to break, we dispose of it, come back and get a new one.
Yeah, I think there needs to be talk about mass hygiene, because you can't keep reusing it. You have to throw it out.
Absolutely. So let's bring on that guest. She doesn't have a lot of time, but oh man, this is an awesome guest. She reached out to me through a kidney warrior, Ray Harris. Our guest, she works with ProRepublica, which is a nonprofit newsroom that investigates abuses of power. So now, we have an investigative journalist from an organization that investigates abuses of power, Tamika. She has a powerful story to share from her investigative report on the Black American amputation epidemic, because as we talked about before this broadcast, there's so many Blacks that have amputations that have been unnecessary because of type 2 diabetes.
Correct.
So, let's bring our guests on. Without further ado, we got to give it a special VIP guest treatment. Without further ado, we're going to bring on ProRepublica's investigative reporter, Lizzie Presser. Here we go. Hey, Lizzie,
Hi.
How you doing?
I'm good. Thank you for that welcome.
Oh, absolutely. Welcome to Urban Renal Talk with Tamika and Steve. I appreciate you taking the time out of your busy schedule to come on our show.
Thank you for having me. Appreciate it too.
So, Lizzie, I'm just going to get right to it. What inspired you to write a story titled The Black American Amputation Epidemic? Because there's many stories you could have wrote. You could have wrote on autism, the pharmaceutical companies, big tobacco. I mean, there's just so much going on as far as abuse of power in the world today behind capitalism. What made you focus on Black America amputation and the epidemic from that?
Yeah, so I was assigned to take on a beat of health. And so I wanted to look at the healthcare system through the lens of one condition. And I thought I should try to focus on diabetes and try to understand what's going on with diabetes in America today. It's one of the most common chronic conditions in this country. It costs the government an enormous amount of money, and it's affecting far too many people in America. And so I wanted to take a look at the healthcare system through that one disease process. And so I started just by looking at the statistics of complications of diabetes. And really, Steve, it was just the statistics that stunned me. I was appalled to see that diabetic amputations were rising quite significantly. They've risen 50% in recent years. And when you hear and see all of these innovations in diabetes care, it doesn't make sense, right? It demonstrates there's a real problem in the delivery of care if amputations are rising. And then on top of that, I was deeply troubled by the fact that if you're Black in America, you're more than 3 times as likely to have a diabetic amputation than if you're white. And so I wanted to understand what's driving this rise and what's going on with this disparity.
Now, let's. I read your article, and for people, I'll put the. Can they just go to ProPublica.org to see that article?
Yeah, and we can post it in the comments too, so there's an easy link.
Okay. But talk about Dr. Faluso. He seemed like he was the main character or subject of this whole story. Talk about Dr. Faluso. He seemed very interesting.
Yeah, he's a great guy. So I followed a doctor named Falusho Fakuridi, who was born in Nigeria and came to the States when he was a teenager and became a cardiologist. And he ended up deciding he would move to the Mississippi Delta because that's where he felt like he was most needed. And he thought he would work on hearts. He's a cardiologist. And he set up shop in Cleveland, Mississippi. And every time patients came in, he asked them to remove their socks because that's what he had been taught in medical school. And what he quickly realized was that more disturbing than the heart conditions that he was seeing were the leg conditions. And he would find patients after patients who had cold or hairless legs, who complained of pain, had been misdiagnosed with gout or arthritis, had blackened toes or just discoloration in the toes, and a low pulse in their feet or at their ankles. And what he was realizing quite rapidly was that there was a very high rate of what's called peripheral artery disease, which is when the arteries in your legs clog. And that if he didn't do something about it, the amputation numbers there were going to keep rising. And so I followed his journey to trying to set up a practice that was really focused on preventing unnecessary amputations in the Delta, and then also what he's been doing in DC in terms of trying to move politicians to create better policies that protect patients who are underserved by the medical system and deserve better and more diligent care so that they're not losing their limbs when they don't need to be.
Now, through your investigative reporting, did you find this not only in Delta, Mississippi, but is this common across the United States?
Yeah, that's a really good question. And I think sometimes people who aren't in Mississippi read stories about Mississippi and think it's a Southern problem or it's a Mississippi problem, and that's not the case. I mean, before the show started, we were just talking about how you guys have seen amputations in the clinics where you've worked. It's quite common. They're more common in poorer neighborhoods, which is another troubling thing to read, because you're starting to see how people who simply don't have the same means are being treated differently by the healthcare system, are losing their legs at a higher rate. And when they lose their legs, then that means that their mortality rate rises as well, right? And so it's an inequitable distribution of care for sure. And it is not just the Delta, but it is often concentrated in lower income zip codes in America. There was a crazy study in California that showed that there, in the richer neighborhoods, the richer zip codes had a likelihood that was 10 times less than the poorer neighborhoods of getting an amputation, and vice versa.
Wow. I mean, someone knows someone that has an amputation in the Black community. I mean, that's just the plain truth. But let me ask you, through your reporting what seemed to be the cause of people getting these like these wounds. I mean, was it lack of education where they didn't know they had diabetes and they saw something or they didn't know they had a sore on their foot and it just kind of got out of control?
Yeah, it's a good question. And I can't really speak to the whole problem, but what I was seeing was something that's not so dissimilar from dialysis care, which was people who just weren't getting good primary care that was focused on what was going on in their legs. And so primary care doctors who weren't testing to see if they had clogged arteries in their legs, so that they didn't even know that they had peripheral artery disease. So that often what happens with diabetes is you get neuropathy, you can't feel very well. And so they couldn't even feel the pain of their legs that they would normally feel. And that means that if they stepped on something like a tack, or if they accidentally nicked themselves when they were cutting their toenails, that wound could continue to fester and would have a really difficult time healing, and that could lead to an amputation. But the reason I bring up kidney disease and all this too is because I'm hearing really similar stories of people who are crashing onto dialysis, right? People who were never told by their primary care doctors that their kidney function was declining, and who then are surprised to find out that they need dialysis. And is that an equitable way to provide care to people? Yeah. I mean, it seems to me like a pretty troubling one.
Mm-hmm. And it's not just troubling, it's stressful, because these people have quote unquote normal lives, and then being told they have kidney disease just feels like it just strips them of everything.
Yeah. And then if you're told early that you have kidney disease, that gives a patient or a person just the opportunity to try to do everything they can so that the kidney disease doesn't progress to kidney failure. Right. But if you're just told you have kidney failure at that point, you have very little in the way of options. It's a completely different situation at that stage.
Right. I notice a lot of patients in dialysis, the ones who are diabetic, wind up with some type of amputation. And sometimes it starts with the foot. Then once it goes to the foot, it goes to the knee. And then when one finger comes off, but no, it starts with the first toe, the big toe. Then it's the foot,
or a couple of toes.
Or a couple of toes, right, Steve? I don't think they do enough to prevent this from happening to them.
I can talk about that a little bit. So a couple of things just physiologically is that the same, if you have type 2 diabetes and that causes the kidney failure, that's often the same process is happening in your body as the process that's making you get gangrene or blackened toes, right? It's like your arteries are closing down and they're clogged with all kinds of plaque. Exactly. And not only that, but the food, so what you're eating, how you're controlling your blood sugar, whether or not you're smoking, whether or not you're exercising, all of those things will control how that plaque is building up or not building up in your body, right? So it's unfortunately unsurprising that the same people who are progressing to kidney failure and to dialysis are progressing to amputations. That being said, one of the things that came up a lot in my reporting were patients who were having amputations and didn't even know, or hadn't been told by their doctors that there were other things they could do to try to save those limbs. One of the most important things is getting what's called an angiogram. So that's imaging of the leg to see where your plaque is blocked, and how, if it's possible, to remove the plaque from those arteries. And there are doctors, vascular specialists, cardiologists, vascular surgeons, radiologists who have been specially trained to remove that plaque without doing surgery. It's actually a non-invasive procedure. And that could save you your limb at the very least temporarily and give you time to control blood sugars and keep those arteries open so that you don't lose that limb. And so one of the things that this doctor I followed, Dr. Felucio Fakredi, tried to impress upon his patients is that if any doctor ever says, okay, this leg has to go, this foot has to go, this toe has to go, get a second opinion, is what he would tell them. And try to talk to a specialist who's capable of opening up those arteries and cleaning them out so that that leg or that foot or that toe does not have to go at all.
So down in the Delta, before Dr. Faradi came there, surgery was the common practice for diabetics who had maybe a wound or something. Did they try to heal the wound or any preventive care? Because in your story, somebody said surgery seemed to be the common practice. Yeah,
so I don't know if we can make that much of a generalization. I'm sorry to be specific in that sense. I think it was just that it was hard to find a specialist in the region. And that's the case across rural America, right? There aren't always specialists who are going to be available to everyone, particularly in underserved neighborhoods, to be doing the work to kind of open up their vessels. So it was not uncommon to go straight to surgery. Right. One of the things Dr. Fakredi said is that the vast majority of his patients had never had an angiogram. That's totally right, Steve. They had never had any imaging to look inside their legs, which is shocking and really disturbing.
Wow. I mean, I'm sure a lot of patients could have had their limbs saved if they found that out. But if they're in underserved neighborhoods, does insurance pay for that?
An angiogram?
Yes.
If you have insurance, it should.
I mean, like Medicare and Medicaid, right?
Yeah, Medicare and Medicaid should pay for it if the surgeon or if the specialist deems that it's necessary. But you need a specialist who believes that it's necessary and believes that you deserve that kind of limb-saving care. And that's why it's important to seek a second opinion if you see a doctor who is telling you the leg has to go.
Wow. Now, let me ask you, talk about another character in your story, Henry Dostri. Now, this gentleman, before he saw Dr. Felucio, he didn't already had an amputation and was about to possibly lose a second leg, which would have deemed him a double amputee and more or less confined to a wheelchair to the rest of his life. How is he doing, and what's his deal?
No, actually, Henry Dostri is an interesting person to discuss, particularly with anyone who's listening who has kidney disease, because
we got a lot of people with kidney disease listening.
So what ended up happening with Henry was that he did have kidney disease. And so the first surgeon who looked at him said that there was no way to do imaging of his arteries and that they would just need to take off half of the leg. And what Dr. Fakredi did instead was basically, as anyone with kidney disease knows at this point, contrast dye is really dangerous to do imaging, internal imaging, or MRIs. And so if you're a vascular specialist, there are other ways to get around that. You can use this CO2, a colorless dye, and that'll preserve your kidney function. And so that's what Dr. Fakredi did in this instance. He used the CO2 and he looked inside Henry Dostri's legs, and he saw that his vessels were pretty open, and all he had to do was clean out a small piece of the vessel and blood would flow freely to his foot and heal his wound. And he did that, and he saved the foot, and Mr. Dostri is walking around and he's driving and he's tinkering with his cars, and he didn't have to lose a second leg after all.
Oh man, that is awesome. Wow.
So it's an important lesson for patients and doctors, right? Like there are ways to get around. Doctors don't always know what's best for you. It is really important to be talking to a number of different doctors.
Mm-hmm.
And so and the other thing I wanted to say is that I was reaching out to you not only to talk about this story, but to talk about kidney failure. And what I did in Mississippi was spend all this time talking with people who had had amputations because of diabetes. But I'm so interested too to hear how patients with kidney failure feel like they're being treated by the medical system and where they feel like they could be treated better, right? Because it seems like very similar problems. A lot of gatekeeping, a lot of doctors who aren't telling patients exactly what's happening with them or how to prevent further complications, or how to access transplantation. And I want to know how patients with kidney failure feel like this system could work better for them.
Absolutely. So if you're watching and if you got kidney failure, you're doing dialysis, Lizzie is putting out a call asking, if you're getting treated right. You just heard us, so please reach out. How can someone reach out to you if they are interested in sharing their story with you?
So you've tagged me on Facebook, so they can do that. They can message me on Facebook or add me there, or I'll leave my email and my phone number in the comments so that people can reach me that way. But it's just my name, lizzie.presser@propublica.org is my email. But you can feel free to just message me on Facebook too, if that's easier.
Mm-hmm. So we had a comment by Martin Pito. Now he's has kidney disease. He hasn't started dialysis yet. He says economics determine treatment quality. What do you think about that?
Unfortunately, I think it's far more true than I ever wanted to believe about this country. And I think when I look at it in terms of amputations, it's quite stark, right? So the diabetic amputations are occurring more frequently in poorer neighborhoods. So Martin, that goes right to your point. I think with kidneys, it's really stark too. You can't get a kidney transplant in this country unless you can prove that you can afford the drugs afterwards. Right. So that's essentially rationing transplant for people who can afford to pay. So that certainly feels to me like exactly what you're talking about, Martin, that only people who have a certain level of economic security are able to get basic, what I see as basic treatment in the health system.
How did you feel when you started finding all this out? Like, how did it make you feel?
Extremely disturbed and extremely sad. I think I was most disturbed and most troubled by the number of patients I was meeting who hadn't previously known that there were ways in which their doctors could have helped them, saved their legs, and ways in which they themselves could have modified how they were eating or how they were smoking or how they were exercising to save their own legs, right? Hearing patients feel like they were kept in the dark and that's why they had these amputations, and that it was a norm. I think that also really troubled me. There were people who I met whose mothers had amputations and cousins and grandmas and great aunts. And there was this feeling of like, oh, well, that's my fate as well, when it doesn't. It should never be that way. And that's not the case at all. In fact, I would hope that our healthcare system would see that there are these disparities and that there are these clustering of amputations and do something about it. But it actually takes people talking out and getting angry very publicly to make anyone make a difference or start to affect policy change.
Wow, Martin says that's the first question asked when initially seen by a transplant committee.
It's really disturbing to me. I mean, I think we talked a lot, or Steve's talked a lot too here and elsewhere about the God Committee, right? Where back in the day, only certain people who had certain economic means were able to get dialysis. And now it seems like that's been moved over to transplantation.
Right.
Wow. Now, something I found interesting in your article that you had, it was 2 maps that Dr. I call for, how do you pronounce his last name?
Fakarede.
Yeah, Fakarede saw at a plantation museum. One map shows American amputations from vascular disease, and then the other map shows the enslaved population before the Civil War, and they both like kind of contrast each other, almost similar in numbers.
Right.
Yeah, and the area.
The areas is what shocked me, how close in proximity, almost a perfect fit of where it was. So I guess this saying is like another type of slavery or something like that. That's how I took it.
I think there are definitely some patients and doctors who see it that way. I think it's also a way to just understand how our history shapes this country, right? So
right. I'm gonna see if I can pull it up real quick because they got to see this map. So this map right here is of the amputations. Can you see?
Yeah, right there. Wait a minute, come down. No, we can't see it, Tamika. Right there. Right there. Oh, it's
basically the Black Belt, right? It's the same strip of land where you see the enslaved population around 1860, plus Texas. Yes. That's basically the map. And that's not a coincidence. That's the consequence of a series of policies that have excluded Black residents in the South from the same kind of care that other people in this country are getting. And so that's what shocked Dr. Fakarede and made him feel like he really needed to stay in the South to continue to provide a really high quality level of care for his patients in the Mississippi Delta. But that being said, he is one doctor in a pretty small county in Mississippi, and he understands that he can't do everything. This isn't going to be the work of one doctor. This needs to be an entire overhaul of the healthcare system.
Right. Now, you say, despite the great scientific studies despite the great scientific strides to diabetic care, the rate of amputations across the country grew by 50% between 2009 and 2015. Talk about that, because that's astounding. If we, because I've seen it have diabetic education, nurse diabetic educators, foot doctors, people going to wound care, but yet it's still, amputation still grew by 50%. That's like a 6-year span.
And then Steve, even with them going to wound care, it's like, it's not working.
Yeah. The most experts will say that those numbers suggest that the preventive care system in this country is really what's not working. Yeah. And I think, I don't know, I mean, the prevalence of kidney failure in this country is also going up. Incidence seems to have steadied. But those two things are also related. We shouldn't be seeing complications of diabetes increasing. And yet we are. And so that is really why I wanted to look at this story. So how are we failing people? How is the healthcare system failing diabetic patients? And
I was going to say, I believe it's failing them because the real information is not given out there. Like the real information is not being put out there. They put out there what they want them to know, not what they need to know.
Yeah, which is something that I'd love to hear from people on dialysis about as well, and something Steve and I have been talking about, right? Like, how is how are dialysis clinics educating patients about transplant? Are they educating you, dialysis patients, about transplant and the risks and the benefits of transplant versus the risks and the benefits of dialysis? And are these clinics, are social workers helping you get through the process? And what is it like going through the transplant center and the process there? I'm curious if patients are dealing with the same feeling of being left on your own and not necessarily being guided through the process in a way that feels like it's enough.
Oh, I'm sure that happens a lot. I'm sure that happens a lot.
I feel like a lot of information on transplants is not given out there. Like some of the meds that they give them can cause thyroid cancer. I think that they need to know more about that with the side effects of these meds too, to give them an option versus someone having a transplant and they wind up with thyroid cancer a couple years later out of nowhere.
Mm-hmm. Now, Tamika, you got a delay.
It's my internet. I don't know what's going on. Let me try it again. Let me see.
But Lizzie, did Dr. Ferrati, we had a question from Angela. She said, since we're talking, what can we do to make it aware to look for signs of breakdown in the circulation in legs and feet?
Okay, now, so there are a couple of things. I'm not a doctor, so I should say that up front,
sure.
But I'll tell you what I learned, which is some of the signs are if you're not growing as much hair on your legs. So you're becoming, you're just losing kind of density of the hair on your legs. If your lower legs feel cold to the touch, for example. If you start, one thing to do is it's really important if you have type 2 diabetes to always be checking your feet, even under your feet.
Absolutely.
Right?
With a mirror if you can't see.
With a mirror if you can't see, and just trying to make sure that you haven't stepped on anything, you don't have any cuts or any wounds. Wearing protective shoes so that your feet are protected from any cuts is another thing. Not cutting your toenails, but maybe filing them or finding the safest way possible so you don't nick your toe. One of the other things is that a lot of patients I spoke to did have pain in their legs, but they didn't know what it was. So some doctors told them it was arthritis or it was gout. And just ask, can I get tested? If you feel like it might be what's called peripheral artery disease, that you might have built up a plaque in your legs, you can ask to be tested and ask to be screened. If you don't think it's arthritis, if you don't think it's gout, if you think it's something else, ask to be tested for PAD.
Especially if you got diabetes type 2, because I tell people, look, when the doctor tells you you got pre-diabetes, I don't believe in that, but when they start talking like that, I mean, I wouldn't take no medication from them. I would ask them, how do you, change the behavior, your lifestyle, your diet? Because once you get that prescription for metformin or whatever it is, and you keep going back and you managing that diabetes, 5 years, 10 years, you managing that diabetes, you still got diabetes. And the longer you have diabetes, the higher the risk for PAD, which is peripheral artery disease, and coronary artery disease goes up the longer you have type 2 diabetes. So that's why it's important to try to eradicate that as soon as you can through lifestyle changes and diet, before it gets to the point where you have to be on some type of oral glycemic medication.
Right. Steve, could you tell me why there's so many people on dialysis with diabetes that these topics never come up? These doctors never sit down and have a conversation with them. Though they're renal doctors, they know that a lot of these patients are on the machine due to diabetes.
Well, Tamika, I guess back in the day, when I say back in the day, maybe about 8 years ago or so, and some clinics could be still doing this. Mm-hmm. The large dialysis clinics did take the lead and started doing foot checks on patients that were diabetics. Now, that kind of, fell through the cracks. They may still be doing it, but a lot of times, a lot of nurses, and it's going to be honest, you had nurses who didn't want to do it because they didn't want to take the patient's shoes off and socks and look at their feet, or patients were embarrassed because maybe their feet had amputation, toes amputated, whatever preconceptions they had. We still had to do it where we had this little stick where we prick the foot, and ask the patient, can they feel that? And then, you got to feel for coldness, warmth, look for any open sores, any cracks or anything like that, fissures in the foot. And that was that. But if they still do it, I don't know. I don't, work in that. But it would slow it down if you had to do that, because you know how fast it is, the pace in dialysis now. It's really no time to do it.
Right.
You got 4 patients.
Mm-hmm. But even though there's no time, the doctors can still refer them to see a foot doctor. They can still pull up their pants leg and see it for any discoloration. Like, there's some things that can still be done. It's not going to take forever. It's just effort.
Yeah, I don't think, nephrologists, you already know how busy they are. I mean, they go to maybe 6, 7, 8, 9 clinics or so. They go to a hospital and cover. I mean, they're barely in there 2 minutes, 3 minutes with each patient when they come through. Everybody's trying to get their attention. They may need to get a 27, 28 sign. They may need to get this sign. So, I mean, I'm just looking from the point of when I see the doctors come in when I used to work and how fast they went through the unit. It ain't no way they're going to see. I mean, I know what you're saying.
I understand. So even as a technician, right, sometimes we have too many nurses. So couldn't one of the nurses on a day, or they pick a nurse once a month to go around and do foot checks? Like, if they think of a plan, it can work. But no one is thinking of a plan. They just rather amputate.
Yeah, it's unfortunate. Angela asked this question. She said, "I'm transplant person 1. I woke up and 3 of my toes looked like they were burnt. Did all the tests, no answer why this happened. I was just told to start wearing wide shoes. No answer." So, Lizzie, Angela, we don't know her, but other than from here, and we can't make an assessment and see her feet. But is this how it starts? Something like this, where she's saying something like her toes look like they were burnt, and if you go to your primary care and he sees it, it could be maybe misdiagnosed, or maybe something said, "Oh, try to wear wide shoes." Is this how it starts?
I'm not sure I totally understand what it means when you say your toes look like they were burnt, but I have...
Well, meaning like maybe gangrene, or it could be
got it.
Maybe blood.
This can be that. I mean, I've definitely heard stories when I was reporting of patients who had discoloration and just had doctors who didn't take very urgent steps necessarily with that patient to make sure that it didn't progress to gangrene. That might not be what's going on with you, Angela. It could be a whole number of different things. But it is one of the things that I think stuck with me the most in my reporting, and same with when I'm looking at kidney disease now, is if you have the means to just ask to see a specialist, right? To ask your primary care physicians to give you a referral to see the specialist who might be able to make a smarter diagnosis, who might have the expertise that you need to know what's going on, whether it's with your toes or it's the nephrologist you need to see or the cardiologist you need to see, right?
Right. Well, I think right there is the problem. A lot of patients don't have a primary care.
Yep.
So that's another big problem. That's what I'm saying. Like, there can be so many different preventive measures if people just sat down and thought of a plan. Me as a technician, no one's going to listen to me if I come up with a plan of action. You get what I'm saying? I think that's so fair. You know, I may not have the credentials, but I have a lot of the same knowledge as some of the nurses, and I've been doing this longer than some of the nurses.
Yep.
Now, Lizzie, just from your investigation, and it seemed like this would be obvious in the healthcare system, why nothing is being done to correct this problem or to decrease the 130,000 amputations that go on each year?
Well, first of all, it goes back to what you were saying about nephrologists and dialysis centers. Primary care doctors in this country are overwhelmed, right? They often don't have that much time with a patient. And so by the time they get through their checklist of everything they need to look at, something like PAD doesn't even make the cut. And so there are a lot of primary care doctors who just simply aren't screening in a way that would help patients begin to do the work to prevent a complication like an amputation. So what Tamika was saying. But then the other piece of it is, right, there are a lot of patients, there are a lot of people in this country who don't have access to primary care on a regular basis, don't have a primary care physician, are underinsured or uninsured, and so are only going to the doctor or the ER when they have an emergency, when they're super sick. And so that's where you're seeing a lot of the most complicated amputation cases come in, right? People who just simply haven't gotten any care and were hoping that they would be able to treat it themselves, couldn't afford to see a primary care doctor, perhaps, or just wasn't part of their practice because they weren't amply insured or it just wasn't what their family had done, right? So those are all things, but then it's also just, we have a really disjointed healthcare system, which is something we're seeing come into focus with COVID. And I think a lot of patients, I mean, I certainly didn't realize how important it was to advocate for myself as a patient to get the kind of specialty care that I would need, right? Like, who knows when they go see a primary care doctor to say, well, let me see a vascular specialist to see if maybe this pain in my legs is something more. I certainly wouldn't have known that if I had pain in my legs. So there's all of this burden that's put on the patient, and the patient isn't a medical specialist. So,
wow.
But I think
no, you're right.
Inform them with something to give them some options, not just dismiss them.
Yep.
Well, I think they should give them more than one option. Like, okay, so if this is our plan of care, you know, well, we're going to try this. If that don't work, we're going to try that. Not just stop at that one thing that's not working.
Yeah.
Now,
I mean, one of the things just on that point about education that I found quite disturbing with dialysis is if you're a dialysis center and you get a new patient, you technically, under the law, need to inform a patient about transplant.
Yes.
But there's no definition of what informing a patient about transplant means. So you just get to check a box. And all you have to say to your patient is, there's this option of transplant. Do you know about it? And if the patient nods, you can check.
Wow.
I've informed, right? So there's no comprehensive education system for nurses and doctors and dialysis centers to be saying like, hey, these are your options. You're on dialysis now. These are the risks and the benefits of dialysis. These are the risks and benefits of transplant. Here is how we would move through the transplant process, right? None of that has been systematized. And so it's quite possible that you're at a center where the education just isn't very good, or you could otherwise be at a center where the education is great, but you don't have any way to know.
Right. Well, I think sometimes with some of the information, I think it's when it's given. Like if a person is just getting on dialysis, they don't hear you. They don't hear you they don't hear anything. They're coming in there and they're just seeing. Mm-hmm. And the images is pretty much stuck in their head until the next month. Then I feel like you should go back and have that first conversation back with that patient and give them more information.
Yeah, but what she's saying, Tamika, I hear that, but I think what I'm hearing is there's say it could be an office, somebody could be a transplant coordinator in that clinic or in these clinics. So when a person comes in, that they can see that transplant coordinator instead of maybe talking with the social worker or expecting the doctor could do it. It's a systematic person in place that can initiate that. And that's not happening. And why I believe it's not happening, because why would a Fortune 500 company that's being traded on the New York Stock Exchange want to decrease their profits by promoting transplant like that? Because they can see if a person get a transplant, then that's one machine that's not work. Somebody else is going to probably be on that machine, but that's one patient or one, as they look at it, revenue that's gone. And that's just my opinion. I mean, because Lizzie, I believe you're right. There should be something set in place to automatically tell a person about transplant so they can have the option of doing that or preemptive transplant, because they may know somebody who may want to donate, but by the time that person find out, they probably be on dialysis.
Yeah, people need to be informed. Sorry, go ahead,
I do think that there should be. I do think there needs to be someone in place there that knows more about transplants and that can sit down and talk to the patients about transplants. That can do more education. Now, I remember when we used to have like some of the reps from the hospital come talk about transplants, but I haven't seen that like in the last year and a half.
Wow.
Yeah, I haven't seen that.
I mean, at the very least, I mean, it's surprising to me that people aren't getting even just packets of information that are very specific, about transplantation. So at the very least, I don't know. I would imagine that the least that dialysis centers could do is provide written education, but really it is about a conversation and making sure that patients really understand the differences in the treatments and what their concerns are and what they want, right?
Two different things.
So basically with your story, what I get out of it is we need to have preventive care. That definitely needs to be promoted, because you wrote, you say, I quote, "It is the cardinal sin of the American health system in a single surgery, save on preventive care, pay big on the back end, and let the chronically sick and underprivileged feel the extreme consequences." What did you mean by that?
I still stand by that, even though it was quite a strong statement. What I meant was that the American healthcare system's interest in saving money creates pain for the people who are most underprivileged in this country, and quite literal pain. And in this example, it was amputations, which are, by one measure, the most preventable surgery in America. We should not be seeing a rise in diabetic amputations. We should be seeing a very low rate of diabetic amputations. And in fact, it's quite high. We're seeing 130,000 diabetic amputations a year. And I call it the cardinal sin of the American healthcare system in this story, because this is an example of a way in which the healthcare system has been stingy on the side of preventive care, right? Hasn't been providing ample preventive care to everyone. when they need it, and longitudinal care, continuous care for people with diabetes, which is what all experts will tell you is necessary for patients with diabetes. And the consequence is that people who live in poorer neighborhoods, minority populations as well, are more likely to experience a diabetic amputation.
Now, would that include fingers as well, digits?
So it's a good question. You're much more likely to have lower limb amputations than upper limb amputations. At one point, I understood the science of that, but if you asked me to do it again, I wouldn't be able to. But it is more likely to be your lower limbs. And I think I'm quite concerned because the figures in terms of amputations, the disparities really track across to kidney failure too, right? If you are Black in this country, you're 3 times more likely to have a diabetic amputation. You're also more than 3 times more likely than a white person to have kidney failure, right? So what is happening? And what is the care that is not being provided in terms of kidney failure? Preventive care. And it's also this thing about what we're talking about with transparency. Just who is the holder of information, and how is kind of the route to preventing further complications? How is that information distributed or withheld based on who your patient is?
Right. I remember reading an article maybe like 3 years back. I sent to Steve. It was like the stores that they put in the urban community are put there purposely, like the dollar stores, and then they put the processed food in the freezer to say that is a food market because you can pick up food there. They have the Dollar Generals and the Family Dollars in the urban community, and they have a freezer section. So they say that is a food market because you can buy frozen food there. Everything there is processed. When I go in the suburbs, you cannot find a dollar store. You have to go in between both worlds to find a dollar store. And if you do find a dollar store, that dollar store been there 25 years, and the closest thing to anything they have near is water and some chips. You know what I'm saying? But they put certain stores in certain areas.
Yeah, they do.
You know, like there's no Wawa's in the hood, you know, but there is McDonald's.
Yep. Yeah, it was interesting. I spoke to this epidemiologist of kidney transplants who's at Hopkins, and she comes from the Delta. And she was talking about how when she first moved to Baltimore, she thought it was going to be a city of opportunity where people just had more access to the things they needed than she saw in the Mississippi Delta. And then the way she describes it was that it was actually just the same thing by other names, right?
Yeah.
It was instead of getting groceries at gas stations, people had to buy their groceries at dollar stores. Or instead of not having a car to get around, they had to take these ridiculously circuitous bus routes to get anywhere. Yeah, right? So it's the same problems, just shielded or masked in a different way.
Lack of access to fresh fruit and vegetable, lack of resources, transportation.
Yes. And they even took out a lot of the supermarkets because they said that it was a lot of theft and the supermarkets weren't making money. So they took a lot of the supermarkets out and replaced them with quote unquote mini marts.
Yeah.
Because they say in the urban community, the supermarkets don't make any money. I don't know the supermarkets they go to because all the supermarkets in the urban community are full of people. So,
do you find this a lot doing your investigation, Lizzie? Angela said, also I find that primary doctors and nephrologists with kidney doctors not in agreement. So I just use my primary for the approval for me to go to the other doctors. I wonder if she can some kind of always make.
Yeah, that's a big problem for a lot of patients, right? They need to go through their primary care doctor often to get their referrals. But that's time, and it's often money, and it's exhausting for everyone.
And let me tell you, I had a kidney doctor back in 2002. when I was dealing with some kidney issues, that was a primary care, and well, she was a internal medicine doctor, primary care, and a nephrologist. But then she stopped doing the primary care because she was just getting so many patients. She couldn't like go between the both like that. And so she had to focus strictly on that nephrology aspect of it. But I know but it was great to have the, primary care and nephrologist and all the same, but you don't find too many of that these days.
Right.
No, you don't.
You know what, Steve? I think it'll be a good idea if they offer telehealth to the patients in the center, to sit them in a room and have them sign up with a doctor and talk to them through telehealth. So if they have an appointment, they go off the machine, they go in the back room, and they're able to talk to the doctor. And if the doctor needs to see them, then they could go into the doctor's office.
Oh, who's gonna take them back then, stuff? I mean, I hear what you're saying, but huh?
I mean, they hire people for dumb stuff. They can hire someone for something serious.
Yeah. I mean, I know in the perfect.
And I'm only saying this, Steve, because this will assure that patients are seeing their primary care doctors.
Right.
No, they're just sitting in front of a laptop or some type of screen where they're talking to them about the problems they're having. If the doctor feels like they need to be seen, they give them an appointment.
Right.
I mean, they can even be seen by the nurse practitioner.
Yeah. I mean, I think what you're saying is so important. Like here are a group of people who are physically going to dialysis 3 times a week and sitting there for hours at a time. Where's the coordination of care, right? How is that dialysis center working or not working with all the other doctors that this patient needs to see?
Years ago, when I first started, many moons ago, when I first started dialysis, they used to communicate. And this was in the late 90s. They used to communicate with one another. Now, what happened in the last 20 years, I don't know. But they used to communicate with each other.
I think maybe they increased the population explosion of patients, and it's like they can't handle that many people. I mean, look at the office visits and stuff. It's just really ridiculous. So, Lizzie, I know your time was limited, and we're at the hour mark. But what do you want to tell people who's watching this show that may be diabetic, type 2, or dealing with kidney disease? What would you say to them based on what you found out through your research? I mean, your investigation, and also how can people reach you to share their story with you? Because I know you said you're doing some work on transplant and kidney disease.
Yeah, that's great. So I think in terms of amputations, I think a couple of things. One is most amputations are unnecessary. Most diabetic amputations are unnecessary, which means that there are ways to prevent them. So if you see signs of a potential blocked artery in your leg, whether that's coldness of your leg or discoloration or hairlessness or just pain that doesn't seem to be arthritis or gout, be proactive and try to find someone who can help diagnose that and see if there are clogged arteries that can be cleaned out. The other piece of that is if you hear a doctor tell you that you need to have limb cut, get a second opinion. You don't need to necessarily just take the advice of one doctor, especially if what the doctor is saying to you doesn't sit right with you. Those are the 2 things on amputations. And as Steve said, I'm now working on a long story on kidney failure and how patients feel like the system could work better for them and where they're not getting the information that they want to get and feel that they deserve to get. So that means talking to patients who crashed onto dialysis and wish their primary care doctors had told them earlier that their kidney function was declining. And it means patients who sat on dialysis for long periods of time, who weren't told about transplantation, or weren't told in a meaningful way about transplantation, or patients who made it to the transplant center and had a really difficult time working through a really complicated process. I'd love to hear your stories and where you think and where you know that the system should be doing more for you. So you can find me on Facebook. I'm tagged in Steve's post. Or you can email me at my first name dot my last name at propublica.org. So it's
let me put that up there.
Great.
So it's you said Lizzie.
Yep. Presser.
Okay. Oh, your last name. Okay.
Mm-hmm.
At propublica.org.
Perfect.
Okay. Yeah, I was looking at the story that you just worked on, and you had another person that was a character. What was her name? Lavinia Stokes, who kind of fell in the same position as the first gentleman. She had an amputation from and then her second leg was going to be amputated due to a pedicure nick.
Wow.
And she found Dr. Faluso, and he saved her leg as well.
That's right. That's right. Her leg. She still has her leg since I wrote the story. Yeah, she hadn't been tested for peripheral artery disease before she lost her first leg. So that was one of the things that angered Dr. Faluso Fakarady the most, because any patient who's going to get an amputation, for the most part, the vast majority of them should be getting these angiograms to see how their arteries look. There are very few circumstances in which the situation is such an emergency that shouldn't be done. That's right. That's absolutely. The right email address.
Yeah. Sorry about that. I just noticed that. Yeah, that's serious. Somebody getting an amputation, and for that to be happening just like that, or to just say because your parents had an amputation, or your mom or your dad, that you're at fate to get one too, and not even do nothing about it it's crazy.
Right. Yeah. And you know what, Steve, on our part, like, we have to stop ignoring our body. Stop using remedies from grandma, and advocate for yourself. If you feel like something is not right and the doctor's telling you you're fine, go get a second opinion. It's okay. Because I've seen it in the clinic. I've seen it recently where one of the patients was telling the doctor that he was having a problem with his foot. And the doctor was like, oh, you got too much fluid on. Stop putting so much fluid on. Then after I came back from having Zoe, well, his leg was gone. And he was pissed because he said he kept telling the doctor about his foot.
Wow. Wow, that's absolutely crazy. Now, Lizzie, Angela said you kind of comfort her by sharing what you shared because she thought she was losing her mind.
Wow.
I'm glad to be a comfort. And Angela, if you want to talk offline, you have my email now as well.
Yes, people, if you want to, share your story, you may be, on the front page or something. Who knows? No, but
get your story out there.
Yeah, that's crazy. But Lizzie, I know we ran over time, but thank you so much for coming on Urban Renal Talk with Tamika and Steve and sharing this information. And when you finish with your story with the kidney disease, we definitely would like to have you back and share what you uncovered with that as well. Because there's nobody doing nothing like this. And that's why it's important to the kidney community. There may be other stories about dialysis, but there's nobody coming on this platform like you or David Chrisman, who we had on a month ago, talking about these disparities and disproportionate rates that's happening in the urban community. So thank you for shedding light on this.
Mm-hmm.
Thank you guys so much for having me and for the work that you do. And we'll stay in touch.
Oh, absolutely. So if anybody want to reach out to Lizzie Presser with ProPublica, here her email address, and she's waiting for your calls and email.
Yeah, please reach out. Don't be shy. I would love to hear your stories, and I hope I can write something that helps the public understand in more detail what it means to live with kidney failure and where this system really can do better.
No, absolutely. All right, Lizzie, thank you for coming on. I'll talk to you soon.
Bye, guys.
All right, bye-bye. Take care. All right.
Yeah.
Oh, whoops. Tamika, this was an awesome show.
I can't wait to go back to work. Mm-hmm. Yeah, I can't wait to go back to work and actually sit down with my patients and inform them on this information and what they can do to better help themselves. Because no one is talking to them.
Yeah, I mean, yeah, it's ridiculous. I mean, when you said, people in wheelchairs, and that's not taking away how many people got amputation because they got their shoes on. So you wouldn't know unless, you sit down and do an assessment.
Right. And then Steve, another thing that it does, it takes away for them their quality of life. And that's the nature. It affects them. So not only do they have kidney disease now they have an amputation, that's making them feel less than. Now they got to adapt to this too. So they got to figure out how to move with just one leg on top of having to come into this dialysis center and get thrown in a chair. You get what I'm saying?
No, absolutely. Absolutely. So, all right, man, it's been a night. Yeah, it was a great show. It was a great show.
That article out and give it to a couple of patients and sit there and read it to them also, because I really need them to be informed to take back control of their health. I think the more patients take back control of their health, the alarm will sound off louder, because it's the patients that's really out there fighting and wanting things to change.
Oh, absolutely. And I want to put that article, the link to that article on my page as well.
Yes, I'll put it Health Outreach.
It's called The Black American Amputation Epidemic. So,
wow.
All right, Tamika, it's been a great show.
Yes.
Definitely have a great evening, and we'll talk before the weekend.
Yes. Have an amazing day tomorrow, Steve.
I will. You too. You got to work?
My mom. I have to take care of my mom tomorrow.
Huh?
I actually take care of my mom tomorrow.
Oh, okay. How's your mom doing?
She's, you know what? She's resilient. She's my hero. I can't complain watching her go from being paralyzed from the neck down to walking around. She doesn't have much use of her hands, but what use of her hands that she has, she tries.
Oh, that's awesome. So she's walking.
Yes, Steve. She's walking. My mom is walking.
Oh, awesome.
Yeah.
Awesome.
Yep. She made herself a peanut butter and jelly sandwich. She's able to turn the remote. Her biggest joy is that she's able to give hugs, because at one point in time she could.
Oh, that is awesome.
Oh, yeah.
Yes, God is good.
Yeah.
Awesome. All right, Tamika.
Yes.
Yeah, that's awesome. I didn't know all that.
Yeah, she's resilient. Like, she doesn't complain. She does the physical therapy. She does the she even buys her own physical therapy toys. I call them toys or whatever. Since COVID, people wasn't coming in the house, so she was basically working her own self out.
Oh,
like
that's awesome.
her go for being paralyzed from the neck down. The doctor's saying, "Oh well, you know, she's not going to have any use of her hands and having all these issues until my mom, you know, she can use her hands not well, but well enough." So yeah.
Wow, that's awesome.
She's resilient. She is. That's my hero.
That's awesome. That's awesome, Tamika. I'm glad to hear that. So,
Yeah.
all right, guys, we're going to see you next week on another episode of Urban Renal Talk with Tamika and Steve. Tamika, we got to definitely talk this weekend.
Yeah, we have to. Yep.
All right.
All right. Good night, everyone. And remember, your kidneys matter.
Absolutely. Take care. Good night and have a good evening.
Yes. Good night.